Okay, so I'm very excited about how this webinar is unfolding. There are people participating from LSU Health Sciences Center in Shreveport and New Orleans, Ochsner, Tulane, and Pennington. And what's so cool about this for me is that nobody had to travel, nobody had to leave their office or spend the night in a hotel. So I think we're trying a new way for all of us in Louisiana to collaborate and to teach each other. Today I'm going to talk for a little bit about the role of health literacy in improving health communication in our materials and our oral communication with patients and why that's so important. Many of you on the line we've done research projects with or are currently doing research projects with. Allison Davis at Pennington and Elizabeth Desborough here at LSU, Betty Kennedy at Pennington, Lori Powell in New Orleans, and John Van Cherry up here. So I'm happy that everybody's on the line, even though I can't see you. So the first slide says, I better be health literate after giving my best years of my life to medical training. And the patient says, right, but can you explain any of it to me? And that's what we're going to drill down on today is how do we do that? So why do we need to focus on health literacy? Well, 9 out of 10 adults have difficulty using health information that is routinely available in healthcare facilities and in the media. And we as clinicians and researchers often fail to grasp the gap between what we want to communicate and what patients actually understand. The other huge point of this talk is that the demands and expectations of patients for patients and research subjects are increasing, and health-related decisions are becoming more complex. Everybody's got to have insurance now, and that is overwhelming to many people. Research subjects have to understand biobanking and genomics, a little bit about the human gene, and all of that is a sort of brave new world for all of us. So what is health literacy? Well, when we defined this about 20 years ago, we defined it, and the National Library of Medicine still holds to this definition, that it is the ability to obtain, understand, and use health information to make informed decisions. It is linked, numerous studies, probably close to 1,000, have linked health literacy with poor health outcomes and less likelihood of participating in clinical trials, and we'll drill down on that a little bit too. So I'm sure I'm preaching to the choir here to report that Louisiana ranks 49th in literacy, 50th in overall health, 47th percent in obesity, Allison, preventable hospitalizations and cancer deaths, and 39th in diabetes. So we all have our work cut out for us. Some of the studies that have been conducted have positively linked health literacy to understanding of consent and procedures for clinical trials, ability to interpret labels, food labels, prescription labels, other health messages, ability to take medication appropriately and safely, the likelihood of receiving preventive care, they're more likely to have delayed diagnosis. They have poorer knowledge, confidence, and skills in managing their chronic disease, poor physical and mental health status, more ER use, avoidable hospitalizations, and readmissions, which is a quality indicator now, and greater disease-related complications and mortality. So we have a problem. This research that on this slide came out of Vanderbilt recently, and they were testing patients at North Carolina, Tennessee, and I think Kentucky. Up to 50% of the primary care patients did not comply with care recommendations. Less than 20% recalled what was just told to them in the doctor's office. So the more we tell people, the more they forget. Less than 50% knew their discharge medication or their discharge plan, and this is a huge problem as we're discharging people from clinics, the emergency room, and hospitals. 20% don't fill the initial prescription. 50% don't take prescriptions as recommended in this study. And so what they said was it wasn't just this, but the navigation of the healthcare system is really complex. You often have to see a different provider in a different building on a different day, and they're asked to perform more complex self-care changes. In being discharged from the hospital, the family caregiver is often asked to provide skilled nursing care with equipment and wound care without adequate training. And they are often very afraid that they're going to injure their loved one. Clinic times and hospitalizations are shorter and shorter, and understanding and using health insurance is overwhelming for most of us. The NIH says we can't blame people for not understanding information that's not clear to them. And they point out that everyone, no matter how well educated, is at risk for misunderstanding health information if the issue is emotionally charged or complex. And there's some emotional component just being a patient in the doctor's office, especially if you're anticipating or concerned about test results not being good. Often when you're told you have a diagnosis, patients don't remember much after that. And the NIH recognized that in most cases, physicians and other providers try and believe they are communicating accurate information. The information is accurate. It's just, can it be understood and can it be acted on? Patients may believe they've understood directions. They may be embarrassed to ask questions. You've got to have the vocabulary and confidence to ask the question to confirm understanding. We don't know if a patient has understood what we have told them unless we confirm it using the jargony catchphrase, teach back. And one of the things I teach medical students, and this has become, I think it's become more and more prevalent, it is really difficult for people to separate evidence-based information, especially online, from misleading ads and gimmicks. One of the things that drives the cancer doctors crazy up here is all the advertising for miracle cures with targeted therapies. We are moving in targeted therapies, but we're not there. And the new drugs may cost $100,000 a year, and they may extend your life 6 weeks. But the advertising seems to think it's a slam dunk. Also, I teach the medical students, increasingly patients are going to ask you about cost, alternative plans, and doctors are going to have to know more about cost and insurance. Will their insurance pay for it? Different plans pay different amounts, and hospitals and health systems negotiate different amounts. So one of the things I want to point out, a lot of people are very interested in health literacy now, but it's not, the onus is on us and not the patient. Yes, the patient may have trouble getting information, understanding it, and acting on it, but the point is, what are we going to do about it? And so when we first started looking at this, the IOM reported on health literacy in 2004, and they said 90 million adults have trouble understanding and acting on health information. And then the NIH and AHRQ funded health literacy research through 2013, 15, but they have stopped having requests for proposals that specifically 15 target health literacy. So here's when things begin to change. Around 2010, Healthy People said we must improve our health communication. The Joint Commission recommends the use of universal precautions, and AHRQ came out with Universal Precautions Toolkit the same year with 20 specific suggestions. For instance, avoid jargon, slow down, use teachback to confirm understanding. The Department of Health came out with a National Health Literacy Action Plan, which they call for making all of us to make health information and services easier for patients, easier to access, understand, and act on. The Plain Language Act of 2010 put all of this in law, and they put health literacy in the forefront of healthcare improvement in the ACA. The CDC put out in 2014 a clear communication index, which is a helpful checklist and guide. And now all the latest stuff in medicine, precision medicine, personalized medicine, genomics, biobanking, the moonshot, 21st century cures, all in the last couple of years, they all have a very heavy communication component. So things are rapidly developing in the basic science, in precision medicine and genomic testing, but it's creating a widening gap in the knowledge base of not just the researchers and patients, but the researchers and primary care doctors. And so how are we going to communicate this information to people, primary care docs and nurse practitioners and patients in a way they can understand and act on? We need clear, transparent information on clinical trials, genomics, biobanking for community clinic patients and providers. That is lacking, and a lot of times the genetic researchers, bless their heart, just have a hard time talking in ordinary words and living room language. So we need to ask ourselves, what do primary care doctors need to know about these clinical trials, and how do clinicians and researchers explain these things to patients in an understandable, useful, and not scary term? Connie and I have done some research on focus groups on biobanking and genomic research, and they said it sounded scary and they didn't know what those terms meant. Vulnerable patients might not be able to understand the information to make decisions about participating in trials. And one of the things we found out is people trust their primary care provider. Their primary care provider is the conduit to the specialist and to clinical trials. Without genomic studies, however, with a wide range of the population, physicians may not be able to offer state-of-the-art healthcare treatments to minority and underserved populations because it's been based primarily in the past on white males that are very well educated. So disparities exist in clinical trials. They exist in recruitment, retention, and trust in clinical trials and biorepositories. Trust is huge. And this gap exists in people who have low SES, limited literacy, or minorities, or live in rural areas where we're just not conducting much research, and transportation is a barrier just to come to the academic center to participate in research, unless you have a specific disease like cancer or diabetes and are enrolled in a clinical trial. It is still challenging. The transportation is still challenging. So a challenge is to ensure a lot of different people are included in biobanking so we can have information to help identify specific drugs, and information can be useful for different groups and different patients. If minority patients don't participate, the knowledge we have for best practices, which is all built on previous research, will remain skewed towards white patients and therapies that work for them. This is just an example of how science and medicine is changing so fast. It is so dynamic, but we have to keep up with the ethics and the communication that goes along with it. We need plain language information. We need strategies to inform and support the 20% of U.S. adults for whom written information may never be appropriate. Also, I want to point out that biobanking comes usually with surveys, self-report surveys that patients have to fill out. Are they accurately understanding those? Are we checking to see what they're checking off? We need strategies to help patients see the value in participating in clinical trials, especially if they're not going to personally benefit. And we need to understand consent and HIPAA forms and communication. We've got to do a better job with that. We just seem stuck there. We need to evaluate creative use of automation to deliver clinical trial information and consent. I'm not talking about a boring video with a doctor in a white coat droning on and on. I've seen some very clever cartoons used to teach pediatric patients and their parents and get consent for colonoscopy. And how do we define success? What do we want providers and patients to know and do, and how do we know we've done it? So I love this cartoon. Here's a scientist explaining genome project, and the kids say, when I ask what little girls are made of, I was hoping he would say sugar and spice. So this is the communication gap that we are often facing. So what is literacy? Well, it's many things. It's ability to read, write, communicate, and maybe get every word in every letter in the same box. Math skills, so much of healthcare, self-healthcare, is basic math skills, particularly in pediatrics or with diabetic patients. Problem solving, judgment, interpretation. And now, John, you need internet skills, right, to be able to function independently in society. And part of what this illustrates is not only literacy is more than reading, it keeps evolving. I mean, 20 years ago, internet skills would not be a requirement. In the Civil War, you just had to sign your name. In World War I, you had to have a third-grade education. World War II, a fifth or sixth grade. The war on poverty, we thought the standard was eighth-grade education. Now, GIs need to have at least a high school equivalency. Here's Louisiana. Notice we have no purple parishes where less than 15% of our population has low literacy. This is based off of the first national literacy survey. It was a household survey. Researchers knocked on doors, 26,000 households, and asked them functional everyday literacy skills. It was scored on 5 levels. Level 1 is the lowest. It's probably the equivalent of reading on about a 5th grade level. If you read on a 5th grade level, you're going to struggle with labels on prescription medicine or over-the-counter medicine. So 28% of Louisiana adults are level 1. That's also true with Shreveport, but almost 40% of New Orleans adults are level 1. You can see a lot of the red parishes are along the Delta, which is probably the result of the plantation society and all of the minorities that grew up there that were undereducated. So then 10 years after the government did the National Literacy Survey, they did another National Literacy Survey and added 56 questions on health. But people, when they knocked on doors, only got 8 of these questions. They also changed up the scoring, which is confusing, but the reason they did, they wanted to know how many Americans were below basic. If your straight literacy is below basic, that means you cannot even enroll in a GED class because you're reading on a 3rd or 4th grade level or below, and you need below basic adult education. But when they statistically looked at the health questions, 14% of Americans had below basic literacy, but 22% had below basic numeracy, or the ability to use math and understand numbers. And that's a point I want to make, that our Americans are terrible at math. If you're a physician, if you're a nurse, if you're an accountant or pharmacist, you keep up. Everybody else kind of loses their math skills, and they lose them faster than losing literacy skills. Also, if you are low income or older or minority, your rates of low basic literacy and low basic numeracy are twice as high. So what do you mean below basic? That's circling the date on a doctor's appointment slips. The no-show rate at LSU is about a third. There are numerous reasons, but one is, have you written that down, or do you have the problem-solving skills to figure out how to get there? Is transportation a problem? In intermediate, where most Americans are, that meant that 2/3 of the people who scored in the intermediate level could figure out what time to take prescription medicine based on the label. And you had to have proficient skills to deal with health insurance. So all of us have figured out, clinicians and researchers have figured out some red flags for low literacy. One of the most common we've encountered is I forgot my glasses, I want to show it to my adult child. Incomplete intake forms doesn't mean the patient doesn't care or isn't trying to answer, but perhaps they can't navigate or fill out the form. Diseases have long words that are complicated that may not be in the vernacular. Missed appointments. Every clinician has experienced this. A patient with low literacy struggles to give a coherent sequential history. They'll go off and tell you stories. Not taking their medicine correctly, asking fewer questions, and lack of follow-through with referrals. Do you have to go someplace else for a lab, for a test, to see the diabetic educator, etc.? So this is a video that illustrates it's hard to be a patient. These were patients in private and public sector several years ago in Shreveport. The internists are internist at Emory, but it is still very current in scope.
Well, I had the transplant for about 15 and a half years, but I've been sick forever. Okay, well, I take baby aspirin, that's something new, cyclosporin, prednisone, and when I make the doctor's appointments, I have to be sure that it doesn't interfere with his doctor's appointments, my doctor's appointments, or their doctor's appointments.
So you don't like to go to the hospital where they give you a lot of papers to fill out?
Paperwork to fill out.
Paperwork.
Yes.
Why is that?
Because I can't read that good.
Because you can't read that well. What does it feel like when somebody hands you a lot of paperwork and you can't read?
I feel like you're in another country.
Vitamin D, Nexium, Norvasc, Colestid, Estratest.
When you enter a doctor's office, the first thing, and you're first-time patient there, they're going to give you a clipboard. Sometimes that is very discouraging for a patient who cannot read.
Lipitor, Paxil, Darvocet, Vitamin E.
If I'm really embarrassed or confused or worried about things around me or worried about my child being all upset, I would not be able to read things I normally would read every day.
You know, some of the words that this angiogram, plasty, and all of that, what is that several things or one thing, or it's just a language that I'm not familiar with.
If the patient was transferred to that facility and to any and all insurance companies or other third parties paying or obligated to pay, this is not making any sense.
Tums, Tegretol, Tenormin, sodium bicarb, Cardera.
Do you have any idea what a normal blood pressure is?
No.
Any idea?
No. It's normal?
No, it's not normal. It's high. Have you or anyone ever had to sign a consent form?
Yes. I have hereby, I don't know.
Okay. Authorized.
Miacalcin spray, Nystatin, Aricept, Lasix, Ambien, Imodium when you need it, and vitamin D. I believe that's it.
So the last patient was taking 26 different medicines. In our medicine clinic, often if a patient comes in and their diabetes or their hypertension is not controlled, the resident just adds medicine or ups the dose rather than dig deep to find out, have they bought it, are they taking it, what are the problems. One of the things I teach medical students is the most common medical error is mistake with your medicine. And half of mistakes are caused by patients unintentionally. And patients, I think, have no idea that they need to be careful with medicines and they may not be safe. It is the number one reason that patients are readmitted to our hospital within 30 days. 2 out of 3 patients leave the doctor's office with a prescription. It's easier to get them out of there if you give them something than if you talk to them, venture, if you're on the line, about why they don't need an antibiotic, than just write for one. I teach the medical students that a couple of years ago there were 4 billion prescriptions filled. Now remember, 20 or so percent are never even filled. Why is this an interesting factoid? Well, that's up 50 to 60% in 10 years. And I tell the students, when you're in practice, how many drugs will there be? How many prescriptions will be written? Who is the gatekeeper to make sure that the orthopod and the OB and the arthritis doctor or whatever are not counteracting each other with all the medicine they're giving? Over 80% of adults take at least one medicine during the year. The elderly, people like me, fill 20 prescriptions a year and see 8 different doctors. I'm 69. I'm taking a boatload of medicine. When I was 60, I took nothing. It just happens. 1 in 6 pediatric doses are not dosed correctly. Liquid medicine can be challenging if you have anything but a marked syringe. Over 300 300,000 over-the-counter medicines. The aisles are overwhelming in drugstores. 600 contain acetaminophen, the main cause of liver failure in the United States, main cause of suicide in Europe, and you can only buy acetaminophen in Europe in a blister pack. And most labels and inserts are in English only, and that can be a problem. Okay, let's talk about numeracy. Percentages and probabilities are challenging. Half of U.S. adults can't calculate a tip. Let's look at this tip. Dinner is $23.54. The tip is 5-something. The guy just rounds it up to 29. So how often does something like this occur? 20% of college-educated adults don't know what a higher risk, 1%, 5, or 10. So a lot of times when we're talking about enrolling in a clinical trial or the benefit of this or the benefit of that, we give percentages. But is that meaningful at all to patients? I love this. This came out of Vanderbilt several years ago when they started drilling down on numeracy. So that they tested patients in a primary care clinic and gave them this soda pop label. You drink this whole bottle of soda. How many grams of total carbohydrate does it contain? Well, it contains 67.5. How'd y'all figure that out? Well, you looked at the servings per container. You looked at the total carbohydrates. You multiplied that in your head. But look at how these Vanderbilt primary care patients did. Only a third answered that question correctly. Now, who are these patients? Well, 3/4 had private insurance. That tells me they had a job. 2/3 had at least some college. 80% read above a 9th grade level, but only about a third scored above 9th grade level on a standardized math test. So some of y'all are working with diabetes trials. This is another one out of Vanderbilt, more recent, and they hooked up with people in a couple of other states. And they found that 90% of patients struggle to understand food labels. The FDA knows that and is trying to do a better job. People just can't navigate it, and they don't know how to use it, and it's full of percentages anyway. 2/3 of patients have poor estimation of portion size. We're doing a statewide weight loss project with Pennington, and we've learned that all of us, no matter what our health literacy, are probably poor estimators of the size of portions on our plate. We want to think we're eating less. 25% of patients can't interpret a glucose meter. 40% couldn't calculate carbohydrate intake. 30% didn't dose their insulin correctly. So, obviously, their numeracy was associated with their A1C, their self-management, their confidence, and their A1C. So this shows you it is very easy to make a mistake. It also shows you patients can understand a little bit, but sometimes it's just enough to mess them up.
So what you do, you come out of that room, examination room, with this intelligent woman or man, thinking, God, I hope I don't make a mistake with my medicine, because I did not understand anything he or she said to me.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
So you give her a tablespoon and a half. Can you find where it tells you how many you take? The dosage?
A day?
Take 3 to 2 milliliters. And something I want to point out, I don't actually read this because I know what it says now. So if I had to sound it out, if it wasn't for I knew it, because I've heard it so many times, I would not be able to read that.
Okay.
Every 3 to 4 hours as needed for pain.
Okay. What's a milliliter?
I don't know.
The medication that was given to her was not explained. Well, we didn't use it. In fact, she ran out of her high blood pressure medicine, so she didn't take it. She didn't call me to tell me to fill it. So finally I found out that she had not been taking it. I said, Mother, you can't do that. You have to keep taking that high blood pressure medicine.
When you get your prescription, you get all this stuff and just throw it away because my eyes are not that good.
And then it says discontinue. What does that mean?
I don't know.
How many times do you take these thyroid pills?
Once a day.
Okay. Do you take one of each of these?
Mm-hmm.
Okay, so you take 2 thyroid pills.
No, I take one. I more like got them messed up when I got refilled.
And then, are these stickers helpful?
Nope, don't even look at them.
Don't even look at them.
Okay. What do you take that medicine for?
I don't know what it's for. He just puts me on stuff and he tells me when I have it. I just take it. So we all know these people. Not only are there our patients, they're our relatives and sometimes our friends or sometimes us. So why don't we take medicine like we need to? Well, we may not be clear on how to take it. Forget. When you start taking medicine, you got to figure out how to ground it in your day so you don't forget it. The regimen is too complex. Often the provider hadn't thought about the complexity or not be aware of the other drugs they're taking. Side effects. Oral chemotherapy can extend your life. It can turn it into just a chronic rather than terminal illness, but you've got to take the medicine as directed. But if every time you take it you don't feel better, but you feel worse, you're nauseated or tired or you want an alcoholic beverage or go off with your friends for the weekend, you may quit taking it or not be completely adherent. We've got to tell people the benefit of doing what we are recommending. Some people don't believe medicines are necessary. The cost of medicine, will their insurance pay for it, and the relationship with the provider. So we've done a lot of research with medication labels, and this is just one of our early studies that we published in the Annals of Internal Medicine, and we tested patients in 3 states. I want to throw out a little mentoring here. Our first research was done with just patients in Shreveport, and we had a very hard time getting it published because they said, well, these people are in Louisiana, you know how bad that state is. It's not generalizable. So we now hook up with people in other settings to do research. So these people were, about half were reading on less than a 9th grade level, even though they didn't live in Louisiana, and they averaged 1.5 meds. So about 50% didn't understand instructions on at least one of the labels, and over a third with adequate literacy misunderstood at least one label. And like the woman in the video, almost nobody attended to warning labels. We found out they're not controlled by the FDA or state boards of pharmacy, and the colors are meaningless. They're just software companies putting those out. Then we ask, and this shows you the benefit of a teach back or show back. And we said, show me how many pills you would take. And so what this shows, even with low literacy, 70% could tell us I'll take 2 pills twice a day, but only about a third dosed out 4 pills. Now, for the young researchers on the phone, this is a story that the medicine doctors on my floor told me numerous times, and then we decided to do a research project, and we proved it. It's a little upsetting that even people with adequate literacy, 80% didn't dose out 4 pills. Several studies later, we were in 11 federally qualified health centers in Virginia. And what I want to point out here is we redesigned the label, and you can redesign things too. But in this study, the label had 3 panels. And in one panel, the first panel, we put everything the patient needed to know. This is Mike's. It's his glyburide. He takes this for his diabetes. Take 2 pills at breakfast, carriage return, 2 pills at dinner. And then we begin to play around with the schematic, 2 at breakfast, 2 at dinner. At first, we drew little pills, but patients didn't understand what they were. And even then, the schematic was confusing to some people with low literacy. The middle panel had what the pharmacist needed to know, and the last panel had the warning labels, but the software we were able to use couldn't do better than that. So what did we find out? At baseline, without any counseling from a doctor, nurse, or pharmacist, 60% of the people understood the standard label, but 3/4 understood what I'm labeling as the patient-centered label. But look at adherence at 3 months without any counseling, 30% with the standard label and almost 50% with the patient-centered label. And state boards of pharmacy in California and in Wisconsin have passed this, and this is what the software was able to do in Wisconsin. The top is the old standard label. That's how, if you look at the vial of medicine at home, if you have any prescription medicine, it probably looks like that, and it's wrapped around, and the font is tiny, and it's cluttered. And the label below is their improved label, and instead of the pharmacist and the pharmacy icon getting the most real estate space, the patient's name, take 1 tablet in the morning, take 1 tablet in the evening. And it is just a little cleaner look. So there are things that we all can do to make what we're giving patients more user-friendly. The main thing is we need to put ourselves in patients' shoes. So what do? Slow down. We need to think about what the patient needs to know and do. Avoid jargon. Use living room language. Attend to their culture and their family. Bring in the family member if they're in there. The family caregiver or the spouse or the adult child is often very, very helpful. Use pictures, pamphlets, brown bags of medicine to teach from as teaching tools. The thing that we need to do is limit the information and write down brief take-home information. What's their problem? What do they need to do about it? And then tell them, why is that in your best interest? Teach back or show back to confirm understanding and be positive and motivating. They're the ones that have got to do it. So this came out of Johns Hopkins. I love that. What they say we need to do is strip it down, bring it home, mix it up, and have a normal conversation with a normal voice tone. And our goal is really to engage the patient, to engage them in their health care, to engage them in conversation that facilitates mutual understanding, establishes mutual rapport, and diminishes the social distance. And to bring it home, we've got to make it personally relevant. I had a research assistant who was on a diabetic pump, but she had to take the pump off as she went to run for an hour, and somebody needed to work with her on how she makes it personally relevant to her lifestyle, grounded in the patient's life. And one of the best teachers up here is a cancer doctor, always says, ask before you tell. Cut the mini lectures, talk less, listen more. This is a picture out of a weight loss book that we have, or this is out of a diabetes book that we were funded by the American College of Physicians. And people, even with the lowest literacy, can look at this picture and tell us you're supposed to eat this much meat and this much starch and fill up half your plate with salad or vegetables. So I don't have to tell people on this phone that diabetes and obesity are growing problems. The CDC's picture of the states are interesting. They always start out with Mississippi being the only state that's dark, and then it goes to Louisiana, then it goes all over the South. And we just have a huge problem in this country with both obesity and diabetes. And obesity is the issue that current physicians and researchers are going to have to deal with as last generation dealt with smoking. So, Houston, do we have a problem with self-management communication, self-management of diabetes and its complications and obesity? Much of what we give to patients, we're not thinking what we're asking them to actually do. We need to reduce the complexity. We need to be more helpful in enabling them to do it. And it's not just simplifying material. We need to give them some support, phone calls to prompt them, etc. We need to figure out what parts of our medical regimen are unrealistic and partner with a patient to redesign them so they can do it. So we design these books. What I want to point out is they're focused on the patient, not the disease, and their need to know. And they are designed to help patients not only improve their knowledge and confidence, but increase and improve their health behavior. So there's a You Can Do It page at the end of each book. It's not about giving up everything. It's about making little changes you can live with. Choose one of these easy ideas. I'll eat breakfast every morning. I won't eat seconds at dinner. Just baby steps to improve behavior. So what did we learn from doing focus groups around the country of patients with diabetes? They want information focused on how to manage, not why. They wanted practical strategies for hunger, eating out, exercise. They're confused by portion size, carbohydrates, food measurements, keeping track of their sugar, and they rarely call the doctor's office for help. I don't know how you would call the medicine clinic here if you had a question. What did physicians want? They wanted to tell people about how bad diabetes was, all the associated health risks, about the A1C, the importance of checking blood sugar regularly. So patients and providers, if you're developing material, they want different information, and it's important to consider the needs of both. The provider is probably the conduit to give the information, so they have to approve. It has to be accurate, but it has to be understandable and actionable from the patient's point of view. So we developed a framework. This originally came out of Stanford. It's called the Action Plan. We give patients the guide, and we ask, is there anything that you're willing to do this week to improve your health? Then we wait. We don't jump in. They look at us like deer in the headlights because they're used to us telling them over and over what they need to do. We ask them, what are you willing to do? And then we coach them to be easily achievable, something that they're willing to work on this week. Assess their confidence. If it's not at least a 7, go back and make sure it's easily achievable. We need to teach back to confirm understanding, probably write it down. And then I teach the medical students, ask them if you can call them, set a time, call them, and check on their progress. We are using this in a statewide study in Arkansas on diabetes with health coaches in community clinics in rural Arkansas. So is this a duck or a bunny? Well, it's both. And that's the problem. If the doctor or the researcher just sees the duck and the patient just sees the bunny, you're going to have a communication snafu. So it's up to us to see that in life that it's all ducks and bunnies. So I'm going to drill down for a few minutes on developing user-friendly material. And this cartoon is great because it says, it's time we face reality, my friends. We're not exactly rocket scientists. Developing materials is not rocket science, but it is harder and more tedious than it seems. Connie and I never edit anything once. It's iterative over and over and over and over, and she's going to give you some specific tips on how to start. And you need patient input to confirm comprehension, organization from their point of view, clarity, and cultural appropriateness. Organization from their point of view, Connie and I were funded several years ago to do childhood immunization pamphlets for the American Academy of Pediatrics. And the CDC started out with all the diseases. And what the mamas wanted to know was, when's the next baby shot? And what do I need to watch for? What are the side effects? How do I treat them? When do I come in again for the next baby shot? And why is the baby shot beneficial? So here's some common mistakes. Materials are not organized from the patient's perspective. They're organized from a medical perspective. They go into the weeds about the problem, the statistics, the treatment forms, and treatment options and efficacy. It's more useful to think about the patient, give the most important information first. You might follow the health belief model. You're at risk for having a certain diagnosis or condition. Here's what you can do about it. Here are the benefits. Make it patient-centered. Other common mistakes, given too much information. Health information is usually accurate, but the key message is usually buried. It's not organized from the patient's perspective. It's organized from the scientist or the doctor's perspective. Not attending to white space. Look at this slide. There's plenty of white space. Things are bulleted. Things are listed rather than written in text, dense text. The illustrations are only decorative. The illustrations need to tell the story. You need to think about the title. Is it something you'd pick up? Is it something you think pertains to you? And then you got to think about, how will the patients get it, or how will they be updated? So consider the reading level. Most U.S. adults have finished high school in 2017, but their reading level is much lower. So aim for less than an 8th grade level, and you can check the text on your computer, most commonly with Readability Statistics. You want to?
Yeah. So you can do readability in Microsoft Word, and if you these give you the instructions, but it's really easy to do a quick example of it. And let me show you what you're looking for with the mouse. If you notice, it tells you how many words and how many characters, but down here in readability, and it tells you, this is on a 7.8 grade reading level, and it tells you the words per sentence. And so one of the keys about when you're trying to lower the reading level is multi-syllable words are going to run your reading level up. Breaking sentences up help lower the reading level. And those are just some quick tips on how to get it lower. But it's real easy to do on Word. It's free, and it gives you a general sense of what level you're on.
So you need to evaluate your material. The reading level is the first step. Is the message obvious on the cover, the title, the headings? Do you get to the point quickly? Are key messages easy to pick up? Can the reader easily find what they need to know and do? Is the information actionable? Is it too much? Is it culturally and language appropriate? So several years ago at Northwestern, they developed a checklist, Patient Education Materials Assessment Tool, and it assesses understanding and actionable ability. And their goal was patients of diverse backgrounds and varying levels of health literacy can process and explain key messages if it's understandable. And then if it's actionable, patients can identify what they need to do based on the information presented. This is on the AHRQ website. It's for print and audiovisual materials. Here's an example. Ask yourself, if I were a patient unfamiliar with this subject, does this material make its purpose completely evident? Present information in a logical sequence. Use information headers, bullets, bolding, boxes, and chunk information and provide a summary. They also give specific tips on simpler vocabulary, painkiller, not analgesic, doctor, not physician, send you to another doctor, not referral, enough rather than sufficient, swelling rather than inflammation, helpful rather than beneficial, use rather than utilize. I don't know why we say utilize so much, but it's really just use. And can they identify at least one action they can take and break down the action into manageable, explicit steps? We need to explain charts and graphs. Connie will go over that when she talks about informed consent, and provide tangible tools like menu planners. We did a QI project here on colonoscopy, and here was what LSU sent out. It was written on a 9th grade level, almost 10th grade level, but when we ran it through the PMAT, it was only 50% actionable and 50% understandable. So we were confined by having to do something that the electronic health record could crank out. We had to do it on one page. There are a lot of instructions, but it wasn't organized sequentially. And so we organized it sequentially. We used bullets. We tried to give it a little breathing room. We took out unnecessary words. We organized it from the order of what they had to do a week in advance. And when we ran it through the PMAT, it was 100% understandable and 100% actionable. If I was the queen, we would give a 2-page handout with a little more breathing room. But the no-show rate, the people who showed up and could not even have the colonoscopy was reduced significantly when we used this. Cincinnati Children's Hospital uses templates. I love these templates. They have it for name of the disease or the condition, the procedure you're going to have, meet the team, the medicine, whatever. And all of them look like this. They're colorful. They have tons of white space. The experts say what they want to, what the content they want that's accurate, and then the communication people put it in this template and vet it with parents. So a lot of times people say, well, we just need to show something on an iPad or do a video. Those videos, they need to be 2 or 3 minutes or you just lose interest. There are too many talking heads on videos. They're organized from the medical model, just like the material is. You got to pay attention to tone, to patients' emotions. Then you got to figure out who's going to show it, where, what is the teachable moment. Connie and I are working with some NI doctors at Parkland, and they want, most of their patients speak Spanish, but none of the health providers in the NI speak Spanish. They wanted to develop a video, but they've got to figure out, this is for margin of viability when babies are born at 24, 25, 26 weeks, but they want them to come to the NI within 4 hours. But who's going to show mom the video, and who's going to give this information? The trusted provider is probably the OB nurse at this point. And as I said before, animation created through the patient's perspective is showing some promise. But the bottom line for all of us is there's little research about the efficacy of using multimedia tools, computers, etc., over print material. I want to point out that a lot of the research material that we use, people say, oh, I have to use a validated instrument. That's good, but a lot of times it was validated on college students, and nobody paid attention to patients who have low literacy. And so can the patient independently read, navigate, understand the questions? Likert scales, for some reason, are really difficult for people with low literacy. And yes or no answers are really not good unless you follow up with an open-ended question. Do you know what a mammogram is? If yes, can you tell me in your own words? I want to say a couple of things about literacy tests. The round test that I developed is the most common. There is now a short form literacy test with 7 words. The original had 66. The TOEFL was developed at Emory. The test of functional functional health literacy. It assesses comprehension and some numeracy using a closed technique, like your doctor has sent you to have an X-ray. Is it a stomach X-ray, a diabetes X-ray, a stitches X-ray, or a germs X-ray? In the realm, you just pronounce the words, and in English, it's a quick and dirty screen for literacy. The newest vital sign is an ice cream label, and it assesses ability to read, but it also assesses interpretation and communication. There are 6 questions. If you eat the entire container, how many calories will you eat? If you're allowed to eat 60 grams of carbohydrate as a snack, how much ice cream can you have? So you have to do the math and interpret it. None of these can be given over the phone. If you need to do something over the phone, or if you want to do something clinically and not research, I advise Lisa choose qualitative 1 question. How confident are you in filling out medical forms by yourself? The weakness is it's self-report. And the other thing, if you just think about it personally, sort of depends on what the form is. And I asked a 94-year-old woman that who was highly literate, but she was 94, so she wanted help filling out forms. So here's my bottom line recommendation. Everything we do needs to be written in plain language and formatted for reading ease. Our health information and websites need to be understandable, actionable, and developed with input from patients. We need to use pictures that convey key messages. The message needs to focus on the patient and their need to know and do versus on the disease or the study or the health system or the State Department of Health. Regular touch points we have come to realize are very important. Frequent visits, phone calls, texting, improve patient satisfaction and health outcomes, and the action plan where the patient chooses what they're willing to work on this week to improve their health, invites engagement, problem solving, empowerment, and improves outcomes. So here's where you can email us if you have any questions. And I'm going to take you off briefly and
all participants are now in interactive talk mode.
And so I'm wondering, before we segue to informed consent, does anybody have a question they want to type or ask? Was that a question? Are we all talking? Well, I guess we'll segue to Connie.
Okay. So I'm going to put y'all back on mute and
all participants are now in listen-only mode.
So this is going to pair up with just what Terry said, and this is going to be about informed consent. If I can get... Okay. So to follow up with what Terry was talking about is how does health literacy impact when we talk about informed consent. I sit on the IRB. I usually have to look over consent forms, and I will say over the last year they have started to get better. People have started to take notice about using bullets, which is much improved. But, you know, some of the cancer consent forms are 17 pages long, and that's, you know, that's overwhelming for anybody. So what I want to talk to you about today is why do we want to focus on informed consent, and what can you actually do about it, and what do you need to think about when you're writing up your consent and you're turning in your IRB. So the first thing is, why focus on health literacy with informed consent? And one of the things we know is to successfully engage patients, we have to shift from a research-centered to a more patient-centered approach to clinical research, communication, and care. Oftentimes the research associates do a really good job of this, about bonding with the patient and making them feel like this is a patient-centered approach. The one thing we do know is that clinicians and researchers often fail to grasp the wide gap there is that separates what they communicate and what patients actually understand. We all know that patients often think even after having been told that they may not get any benefit from being in a clinical trial and being told they may get a placebo, that they often believe that somehow they're going to get better. And so trying to communicate with patients is very difficult. Currently, only 12% of English-speaking adults have proficient literacy. Terry went over that with you. Most consent documents are not designed to truly inform patients about the research procedure. Consequently, patients don't often understand the basic concepts. I will tell you this, in consent forms, when you get down to the procedure, a lot of times what happens is that the researcher will cut and paste things that were in the grant. And what you write in a grant is read by a very different type of person than your patient. And so there are all these tables that take you through it. And usually my number one rule is it's better to take a table out and do headers and bullets because patients with low literacy don't often understand how to navigate a table. And so they don't understand the rows and columns. And so one of the things we know is that the research landscape is changing. Clinical research is growing. 2.3 million patients a year sign consent forms. Consenting patients, if there are research nurses or research associates online, know that it takes an increasing amount of time and preparation and change and training. Today's studies are so much more likely to include multiple sites, large numbers of participants, data sharing, and by a specimen with confidentiality concern. There's growing regulatory scrutiny, especially over biased specimens and data sharing. And funding agencies are concerned that patient comprehension is poor, which it is. So when we look at consent, what do patients suggest? They want forms with large print, plain language, and bullets. They don't want the paper forms read to them. They want them discussed with them. There is a very big difference. I can tell you that having worked with a lot of the researchers in the Cancer Center is that their case managers and their research assistants discuss the consent form with them. They don't read it verbatim. And even when they discuss, they often tell you can tell when a patient zones out. And so it's drawing them back in, as Terry said, when you talk about teach back, about asking them, can you tell me in your own words what you're going to get out of this study, what you're being asked to do, what is your part in it? They want one-on-one discussions and multiple meetings. The IRBs and HRPPs, they want clear language forms that adhere to the guidelines. Some standard wording will be required. What I often tell people is, it's really, when you look at the templates for most institutions, the standard wording is less than it used to be. And so a lot of it has to do with what the researcher chooses to cut and paste or to put in there. And so considering both the IRB and the patients, the balance challenge in writing consent forms is you have to identify what the IRB requirements are. What are they looking for? What are their templates? What is their standard wording? And what can be simplified? And a lot of it can be simplified because it's what you put in there. And what is your key message? It's the same as when you're developing patient education. It's what information do patients need and want. I would always say that when we're doing consent forms, we always discuss these with patients. We try and figure out, is something that we've said. We may think it lands one way and it may land another with patients. The other thing to consider when you're talking about consent is not only is literacy, but it's motivation, it's attention. Have they just been told they have cancer and you're trying to, are they distracted? Do they have children in the room with them? And so Winston Churchill has this great saying that says, "This paper by its very length defends itself against being read." And this is a page from a consent form. And the question is, would you or your patients read this? And my hunch is, I can tell you our patients wouldn't. And one of the things that I want to tell you about, like when you look at a page, regardless of what the words are on it, is when we talk about white space, this is very dense. And if you're talking about a patient with low literacy, all they see, if you flip this, if you don't read Spanish, and this is all in Spanish, is all it is a bunch of run-on words. And so they're not even going to attempt it. You've already turned them off before you can ever get started. And so the other issue is bringing the common rule into the 21st century. They've changed the common rule. In September 2015, DHS issued a proposal to revise. And so one of the things to keep in mind is that key changes that they've recognized in studies is they're more likely to include multiple sites and large numbers of participants. That's very true. There's more data sharing. There's a huge push for biospecimens and biobanking. And research is moving towards a participatory model. Volunteers are increasingly expected to be partners in the research study. So two central goals of the proposed revision were to enhance and respect and the safeguard of participants and increase research efficiency by reducing unnecessary oversight to a level of the risk. And so participants are now asked to grant permission to use biospecimens and data for all kinds of downstream research. With our IRB here in Shreveport, it is usually biospecimens you see on a separate, it's usually in the same consent form, but it is a separate signature. So the patients are not signing away everything at the same time. They have to sign for that they want to be in the study, and then there's a separate page that they have to sign that they're allowing their specimens to be biobanked. They want consent documents to be briefer and simpler. That in and of itself is a challenge because we have some very complex studies. And that becomes very challenging when you have to go over all the risks and benefits and what the procedure is if you're talking about over a 5-year time period. There's a lot more going to single IRB of record unless it's required by law. And the thing you need to remember about using a single IRB or is that the local IRB, like here in Shreveport, IRB still is mandated to oversee the project. They're still the one who's responsible if something goes wrong. They're still the one who's responsible for the dreaded audits. And using web-based decision tools to determine minimal risk studies, such as focus groups or surveys. And so on a consent checklist, it's very similar to what Terry had talked about on patient education. Is it written in plain language? Do you use consistent terms throughout the form? Is it written in active and not passive voice? In other words, it's your signature, not the signature of the patient. Is it formatted for reading ease? Is it too long? Is the information manageable or is it overwhelming? What's the plan for discussing the information with patients? Does the form and consent forms actually help the patients make a decision about participation in the study? And will the IRB approve it? And so when we talk about plain language, Terry went over a few things with you. Hopefully you will have access to these slides, but this is to give you kind of an idea of things that you can use. So instead of saying adverse events, people love to say adverse events. It's a bad reaction. Alternative procedure means other choices. If you noticed in the video, one of the young lady who was talking didn't know what the word authorized means. I don't know that occurs to us as researchers in the healthcare that somebody might not know what they say when I give my authorization. It just means to give your okay in writing. Benefit. We throw around that term, risk and benefit. Will being in this study help me? Patients don't know what clinical trials are for the most part. A lot of ours don't. You can either just simply use it's a study or it's a research study. Disclosure means that information you give us. We might notify you, we're going to tell you, or we're going to tell us. If you need to notify us, we use that term a lot. How do you obtain? That means to get or to get a copy. What's a placebo? I would say I probably need to adjust this one. I don't know that IRB would allow you to say it's a pretend drug. I do say that it's usually what's often used is it's a sugar pill, or you're not getting the drug. The protocol is the plan for the study. Randomized, you often see it's like rolling dice. They'll use that as like picking something out that you're selected by chance. Voluntary participation and withdrawal are two significant and important concepts in consent forms. And voluntary means it's your choice to be in the study. There's an easier way to say that. And withdrawal from the study, every patient needs to know they have the option to leave the study at any time they want to. So to simplify, so one of the things I wanted to do was give you a couple of examples. So to simplify and shorten this paragraph, here is the paragraph. You've been selected as a possible participant in the study because you have a moderate to very high risk pulmonary embolism, and it is not known if retrievable vena cava filters reduce mortality or reduce recurrence of non-fatal pulmonary embolism, or if complications of vena cava filters outweigh the benefits in such patients. That is one stinking sentence, and that is actually from an actual consent form. So what is an easier way to say it? You're being asked to be at this study because you've had a pulmonary embolism, and that's a clot that goes from your legs to your lungs. If you notice, the thing is, there are two different concepts in this one long sentence. One is why you've been chosen, and patients want to know that. Why are you asking me to be in this study? And this is a very simple way of saying it. The other is it's telling you that they don't know if the procedure they're using is beneficial, and that's what they're trying to do. So break it up into two sentences and simplify the sentences. So when we talk about making it to the point, the goal of the tissue bank or repository is to support the LSUHSC Department of Surgery research in order to improve our understanding of those molecular factors that contribute to cancer and that may lead to prevention, early detection, and cure. And an example of this, to simplify this, is the goal of this research is to learn what makes cells turn into cancer. Everywhere, there are lots of places you can put who is doing this research. There is a place about who has access to your data. It doesn't have to be at the very beginning because, for one thing, they're either having surgery, they're in the cancer center, they're where they're going to have it that they're doing it. Using the active voice and not the passive, as I said before, breaking text into manageable chunks. We call it lump and clump. One of the things I tell people is when anybody sends me a consent form or sends Terry and I patient education, one of the things that helps me the most to start out straight up is just to take a paragraph and to bullet every single sentence. And that makes it easy for me to look at the information, and it makes it breaks it up for me to be able to see, okay, what can I change? What can be moved to somewhere else? What can be taken out? Usually you want the rule of thumb is to try and keep it one idea per short paragraph. You want to limit the paragraph to 3 or 4 lines. As Terry said before, you want to try and aim for less than an 8th grade level. We already talked about that was just the Flesch Kincaid. And so to chunk information in manageable chunks. This is on a 6th grade level. And if you notice the bullets, this is a research study. You're being asked to take part because you have COPD. You can put the name in parentheses. There are not many ways to treat COPD. New medicines are needed to improve patients' ability to breathe better, especially during exercise. This study will test a new medicine. You can put the name of the medicine in parentheses to help you breathe easier. It is a mist which you breathe in or inhale using an inhaler, which is often called a nebulizer. The FDA has said it is okay, that's another way to say approved, to use with patients with high blood pressure in the lungs. The FDA has not said it's okay for COPD. That's letting the patient know that this has not been approved for COPD, which you're using it for. It's being tested because it may help you breathe easier. That is such a simpler way of reading it. So when we talk about shortening the paragraphs or one idea per paragraph, this one is a paragraph on prostate cancer. You're being asked to take part in the study because you have prostate cancer that is only partially responding to hormone therapy. Abiraterone acetate is a hormonal tablet that has been approved by the Food and Drug Administration for more advanced prostate cancer patients who have received chemotherapy. It is considered investigational for your type of prostate cancer. We will be looking to see if it improved the effectiveness of standard hormonal shots or injection. The prostate specific antigen, which is PSA, is a blood test used in prostate cancer screening and also to follow prostate cancer. In this study, we will follow your PSA level to help determine if it's beneficial. The main goal is to see if it's with prednisone reduces PSA. That's a lot of information packed in one paragraph. And so the way to start simplifying that is you're being asked to take part in this study because you have prostate cancer. We hope to learn if a hormonal tablet, the name of it is in parentheses, is helpful with prostate cancer. The PSA, which is what most people refer to it anyway, and you put the name in parentheses, is a blood test used in prostate cancer to follow it. We will use your PSA level to see if this treatment is helpful. And that's goes from a 12.2 grade level to a 7.5 grade level. White space, the clean layout improves reading ease. It also, especially with patients with low literacy, will gives them a sense that they can tackle this. Like I said before, those dense paragraphs is an automatic turnoff, and a lot of our patients won't even try them. So you want white space, you want bullets and lists, you want bolding, you want simple headers, and you want short sentences. And if you look at this, it has the headers. What else do I need to know? Here are some side effects. You must not get pregnant. What good can come of this? So it's not just a laundry list of bullets. So on this example, this is my one besides many, but my major gripe is I hate that our consent forms start off with what is the definition of a consent form. But that's the way they do it, and our IRB is not changing that anytime soon. So, but which one would you more likely to read? And which one is much more friendly and approachable? This one uses bullets and lists and less text. This was the original consent form right here. This is the one that we helped Bob Walters change, and it's what is informed consent, why are you being invited into a research study, what are your rights, why is this research being done. The great thing too is they put a picture, although this copy may not be the greatest, they put a picture of what the actual instrument looked like that they were going to be putting in, and how long will the research last. A lot of that is over here. It's just much more unfriendly and harder to read. But I would tell you this is an example of a misuse of bullets, because one of the things is it's bullets, it's indented, it's smaller bullets, and there are not as many headers. When you get over here, one of the things is the headers actually are also breathing space in a sense, and it also tells you what you're looking at. What are the risks of the X-ray contrast? What are the risks of the local anesthetic, or what they call the numbing medicine? What are the risks of sedation? What are the costs of being in the study? And so you can misuse bullets as well. When Terry showed, even though these are instructions, one of the things that I thought was also a good indication, I wanted to show you them side by side because this is another misuse of bullets. it didn't break it up into enough headers that were helpful, like the reformed version of it. I actually did a colonoscopy based on this, and I can tell you that the problem with it was you got halfway down the bullets and go, oh my gosh, 3 days ago I was not supposed to do this. And that's one of the reasons why the headers were much more helpful. It was cleaner and it was easier to do. Just like with patient education, develop content from the patient's perspective. Use conversational tone, get to the point. Make key messages easy to pick up. Focus on the need to know and do versus the nice to know. If possible, use pictures to help convey the message. And we always get patient and provider input on consents we're developing, on patient education. The RQ website has cliff notes and bottom lines about being in it. We're asking you to be in a research study. You don't have to be in it. You can quit at any time. It won't change your medical care in any way. Take your time. And then it tells you about the document and what's the goal of the study. One of the things when you're talking with patients, and oftentimes we have to communicate risk communication, like Terry said, our numeracy skills in this country are very poor. And so here are some helpful comments that have been based on studies is one way to not mislead patients, because that's, not only is it do they understand what you're talking about, but we don't want to mislead or overestimate because patients already read enough into what you tell them as it is. So one option is to provide both positive and negative frames. If you say 6 in 10 men who have surgery to treat prostate cancer will be impotent, that means 4 in 10 will not. So you can give them both sides of it. Absolute estimates, not relative. The relative risk is drug X could reduce your risk of breast cancer by 50%. The absolute is it can reduce your 5-year risk from 4% to 2%. Now, if you were reading those, which one would you want? They mean the same thing. But what a patient's going to hear is my risk of breast cancer is reduced by 50%. When you tell them my 5-year risk is reduced from 4% to 2%, that's very different. And it's going to land very different on a patient. You have to think about the way you present data. Usually, one of the things we found is that pie graphs worked the easiest. People just understood pie graphs much easier. You can use this type of chart. The problem happens when you use more than one color. Patients start getting confused as to what all the different color dots mean. So you have to think about that. The thing that we know about informed consent, it's more than the written document. It's the whole process. It's the consent process that you have to take into consideration. And it means preparing and allowing enough time for the session to slow down and connect with the patient before you jump into consenting them. Communicate using everyday language. Walk the patient through the form rather than read the whole form to them. Arrange for a quiet, private, non-cluttered space. And verify and document their comprehension. And that means get them to tell you back what they understood about the consent form. So, one of the groups that we talked to up here at the med school had a really good training session that they did with all their RAs, where they allowed each other to be patients and they gave each other feedback. And so one of the options that is helpful is to role play with the PI and the team. We always do practice sessions when we're doing research on any of our studies. We do it I always encourage, even after I've trained research assistants to consent and stuff, I always encourage them to go home, do it on a family member, do it on a friend, because really it's the practice of it that is going to make you more at ease and more conversational when you go to do it, because it's always a little bit rattling the first times you do it on a patient. sharing with a team member helps because they can give you feedback. This team liked to use flip charts that they had pictures on, and that's what she's showing the patient right there in order to go over the consent form, which was a great idea. The communication is key. Take a few minutes, like I said before, to connect with the patient, to slow down. Consider what your words and your body language may be signaling. If you're tense and uptight, the patient is going to be tense and uptight. Really, the bottom line is teach back is the most effective way to see if a patient understands. Do you know what the goals of why are we doing this research? What's the study about? Do you know what you're going to be agreeing to do? Do you realize that you may have to come back to the clinic 5 times? You know, does the patient get that they're going to have to come back extra times, that they may have to give extra blood, that there may be extra procedure? You know, it's always helpful to ask them what they understand. And one of the ways to not come across as a jerk when you're doing this is instead of, you know, putting the pressure on the patient, oh my gosh, did I remember everything? It's you can say something like, you know, I consent patients all day long, and sometimes I miss some things when I'm going over it, and I just need to make sure that I told you what you needed to know. And so I'm going to ask you to tell me back some things, and that way if I missed it, I'll go back over it with you. And that way you don't put the patient on the spot. Here are some tips that I always say of working with the IRB, and it's really HRPP, it's your human protection, that usually is your first line when you're turning in informed consent. It's to realize they also want effective forms and improved patient comprehension. I always ask before I send in my IRB for help, because for one of the things I know the way our system is set up is if you don't ask till after the fact, when they figure out something they need to ask you, you turn it in, you get kicked back out of the system, then you get put back in the queue when you answer the question back in a different way, and you add a lot of time to it. So I would encourage you to ask questions that you're unfamiliar with beforehand, because it's always helpful, and it actually expedites the procedure. The other thing is, for researchers who are on the line, anytime you make changes to the study instruments or the protocol or the materials, it has to be resubmitted to the IRB. You have to, you know, one of the things that I see that people get hung up with a lot on audits is on reporting on adverse events and their paperwork. Whether or not, you know, as far as I can tell you, since I have been audited, and it was not a pleasant experience, but, you know, when they come to do an audit, the only thing they're going to look at is, do you have your paperwork? I mean, you know, is every I dotted? Is every date the right way? Is everything signed? Because that's the only thing they can measure you by. Security is the name of the game. Password protection, encrypted data. How are you storing your hard copies? How are you sending electronic data? And the bottom line is, at the end of the day, as a PI, you're always responsible for that everything goes on with your study. The buck stops with you.
All participants are now in interactive talk mode.
This is the end of my presentation, but so I want to know, and this can apply to whether or not you have questions or what kind of questions you may have for us. And if you don't have any questions now, one of the things too, Terry, and I wanted to tell you is we are always available. Our emails are on there. Feel free to email us anything if you're working on a consent form, if you're working on patient education, whatever it is, and you need some help, we are more than willing to help you with whatever you're working on. Y'all are a quiet group.
Hello?
Yes.
Yeah, I wondered if these slides would be available for looking at in the future.
Yes. I will make sure that in the past and I know that Tiffany and them will set them up. We will be happy to put the slides up so that y'all can go back and look at them for whatever you need them for.
Yeah, my boss wasn't able to watch this, but she wanted to, and so I said I'd find out if the slides would be available.
Absolutely.
Thank you.
Thank you, Terry and Connie. Great presentation.
Thanks, Tiffany. I will make sure you have the slides.
It was extremely informative.
Thanks, Ron.
Thanks, Ron.
This is Stephanie Goudreau and Sylvia Young from the IRB. It's a great presentation.
Oh, thanks. Thanks so much.
I just had a quick question. You know, we're starting to delve into the new regulations that take effect in January 2018. And I'm curious if you've begun to think about the new broad consent requirement, as well as the new consent requirement of having like a 1-page or 2-page concise description of the consent form rather than the sort of opening statements that we currently have now.
Yeah, I mean, you know, and having appendices.
Mm-hmm. Yeah.
You know, here is I think probably that is well-meaning in the sense of it's designed to say stuff up front. I think my criticism of it is it doesn't get around the length of the document.
Absolutely.
Now we've stuck everything in appendices, and the only thing that I would say I worry about is if you start putting the risk, I mean, you know, if there are 5 drugs and you put the risk and benefits in an appendices, how does the patient perceive that? Like, is that not, you know, a lot of times, I don't know about you, but when I'm reading stuff with appendices, I don't necessarily read the appendices.
Right.
You know, I think this is a move. The FDA was wanting to do the same thing with the leaflets we get when we pick up drugs. You know, the font is about 6-point font, and it's so dense, and they wanted to make a readable 1-page handout. And that generated several studies to try to figure out what is the question is, what is the essential information? If you're going to limit it to 1 page and have some white space and use headers and lists, bullets, etc., then the question is, what is essential? And there's some things we know about informed consent that we believe is essential. It's voluntary. You can get out when you want to. The information is as confidential as we can make it. But the risk and benefits, some of these studies are pretty...
Yeah, I mean, I think where, you know, like with the studies that Terry and I do, we're behavioral scientists, and so we're minimal risk studies. And that bodes well for those kind of studies. I think the problem you run into is when you're talking about cancer trials or you're talking about very complicated regimens that have very complicated protocols that there isn't necessarily, there are better ways, I can tell you there are always better ways to present stuff to patients, but when you've gone over 3 years of clinic meetings that vary between, you know, going back to the clinic once a week for the first month or the first 7 weeks, and then you have to go every 2 weeks, and then you have to go, I mean, you know, patients just get lost in it. And so, I mean, one of the important things that we always try and remind people is consent is a process that is always ongoing. Right. But I would be happy to the other thing that I would tell anybody who's on the line is, you know, any feedback or, you know, that you think would be helpful to add to our talks or anything that you thought was missing, we would love feedback on it.
I think we all should do a research project on a 1-pager. The thing that stopped me is thinking, well, it's going to be so confusing to patients to say, well, you're not actually in this study, but this is a 1-pager if you were in this study, and you need to sign consent to be in this study about consent. And I don't know if that's too abstract. But I do think we need to do some research. It would be great have this statewide collaborative to do some research on a 1-pager.
Completely agree. I'd be interested in helping.
Great. We'll pose that on our call this afternoon, and this would be ideal for something for us to do since one of the moves is to try to have a central IRB. I don't know if that'll ever come about, but it would make life a little easier in some ways.
Mhm.
I'm interested in what was helpful to anybody on the line.
Terry and Connie, there was a question that came across Skype. Would you like me to read it?
Oh, is this you mentioned vetting your patient education materials? Is that
yes.
it? With patients, how did you go about this?
When we have developed, that's a great question. When we have developed materials, we usually what we do is we get to the patient through the doctor. And so we ask them, will you ask some of your diabetic patients or overweight patients or whatever if we could talk to them? Now, it greases the wheel if you have some money to pay them for their time. And we often start out with focus groups, but we don't cold call patients. Now, we will ask friends or people that we work with to vet things all the time. I used to tell Connie, go ask your parents if they can understand this. The first pass is usually not IRB required. We just ask friends and colleagues to give us some feedback. There is always something that you don't think about when you're developing it, or something that is so clear to you, but it's not clear to a reader who doesn't know anything about the subject.
I think, one of the things, too, we've piloted questionnaires we've given before, too, and we've had a couple of our studies where the research assistant came back and said, I don't think this is what you're getting at. The way you're asking this question is not getting the answer that you think you're asking, because patients are interpreting it a different way, and that's always very helpful. Does that answer your question, whoever JHB is? Hopefully so.
How are some of y'all on the phone getting patient input?
Or are you getting patient input?
I'm not sure what you're asking.
Well, if you're developing materials,
oh, okay.
Are you getting patients to look at it? When I'm actually with a patient, when I've identified a patient that I'm working with, one of my favorite questions before I show them anything is, if they have diabetes, first of all, to ask them, what do you think people in your situation need to know about diabetes, or what is it that you wish you had known? Then we often something to respond to, and we go over it point by point. We don't just hand them the whole thing. We'll go over the first sentence or two and say, what does this mean to you?
Mm-hmm.
Okay. I can give you two examples of things that we've asked participants about that researchers may not have thought about. One was when we were doing immunizations, asked to show different brochures and pamphlets to patients, and I can remember this on it, that was carrying the baby in a cloth, and so we were actually interviewing young mothers, and we asked them, so what does this tell you? And they went, what is this bird doing on the front of this cover? Well, that's our generation, the stork and the story that goes with the story. They had no clue. The other one was when we were developing some cancer education, and we were talking to a group of African American women about breast cancer screening. And we talk about, people often like real pictures on the front, people they can identify with. And we we said, you know, what would you suggest for the cover? Do you want to see an African-American woman with her mother? And one of the comments that the group came back with is, we don't want to put a wide range of different races and ethnicities on there, because we don't want just African-American women on the face of it, because it makes it sound like that's our problem, that you're blaming us. You know, that's a very interesting concept and a very interesting idea that probably Terry and I would not have necessarily thought of had we not, you know, kind of tested this out before we developed the material. So we're always very conscious of how does it land on the group we're giving it to? How does this land for the patients we're developing this for?
Right, and a current one was the genomics. It dawned on me that they wouldn't understand what it meant. It didn't dawn on me that it sounded scary. But you never know until you ask. And our experience is patients love to be asked, and when you show them that you're listening and then come back and show them how you've edited whatever it is you have with their input, they get even more engaged in helping you. Y'all have any other questions? We'll get these slides posted online, and email us if you have any further questions or ideas, and then let's see if we can put one foot in front of the other about a one-pager for research and see how that goes down and see what in the world an IRB would do with that.
We appreciate everybody attending today. I hope you all have a happy holidays and good weekend.
Thank you.
Bye.
Bye.